Welcome to the ARDS Alliance Podcast, where we dive deep into stories that inspire, educate, and empower. I'm your host, Paula Blonski. Today, I'm thrilled to welcome Kali Dayton. Kali is the creator and host of Walking Home from the ICU podcast, where she spotlights stories and science behind ICU Liberation, helping patients not just survive critical illness, but return to their lives. She is an acute care nurse practitioner and a leading educator on evidence-based practices like early mobility, minimal sedation, and family engagement. Through her work consulting with hospitals worldwide, Kali translates research into bedside practice change that reduces delirium, shortens ventilation days, and preserves dignity and functions for patients and families. We're going to dig into what really happens at the bedside, why sedation isn't benign, and how every team from respiratory therapy to nursing, PTOT, and physicians can be part of changing outcomes. Kali, welcome to the show.
Thank you so much for having me.
Absolutely. I'm really excited about this one. So can you tell me what moment or patient's story sparked your commitment to ICU Liberation and inspired Walking Home from the ICU?
I had started my career in 2012, or my critical care journey in 2012, in an ICU in which patients were awake right after intubation and mobilizing, which we'll talk about, right?
Mhm.
I knew nothing else, and then I became a travel nurse and found everyone was sedated elsewhere, and I did that for a few years, thinking that that was must be okay if everyone's doing it. Maybe I certainly fell into the belief that it was sleep. I maybe even joked about sedation, fell into a lot of the culture that exists on the clinician side of the ICU. And I had gone probably 6 or 7 years before ever hearing from a survivor what that was actually like. I'd had survivors come back to my wake and walk-in ICU and were grateful for our care, were very honest about how hard it was and things like that. But I feel like when survivors come back to the ICU, it's a little bit biased, right? They're the ones that are able to come back.
Mhm.
But nonetheless, I had again sedated people for years. And I was in grad school. I was back in the wake and walk-in ICU. I was super confused as to why now I was treating patients completely different and seeing totally different outcomes.
Mhm.
I was looking into the research, realizing some of the harm of sedation as far as how much it increases chances of dying, chances of staying in the hospital for a lot longer, going to rehabilitation, all these things. So I was kind of starting to connect the dots, but it wasn't until I heard it from a survivor that the fire just exploded. I was on a plane ride. This is when I was trying to figure out what I was going to do for my dissertation, for my doctorate.
Mhm.
And this is what did it for me, is a survivor telling me about their experiences. And he didn't use the word delirium, but I could recognize that he had delirium. And when I mentioned that, it meant nothing to him, which for me was, it's hard to explain to survivors like the clinician perspective. But for me, it was like, well, buddy, you were confused.
Right.
You weren't really tied down in the middle of a forest. It was just a bad dream.
Mhm.
And but he spent probably like 20 minutes plus just talking about trying to articulate his experiences during his delirium, and he was sobbing.
Yeah.
I was a complete stranger on a plane ride, and this guy was in his like mid 40s. And I was so impacted, not just by the details that he shared, but the signs of deep trauma and how much it impacted his life 4 years after.
Mhm.
For me, I had never heard anything like that before.
Okay.
I just was so convinced that it had to be a fluke,
Mhm.
that he had to be an exceptional situation in case, that there's no way that's what people usually or commonly experience when they're sedated. But I had this nagging curiosity, like I had to confirm that assumption.
Right.
I had to know how common it was. And so I went to survivor groups because who better to answer my questions, right? You guys are the experts.
Right.
I thought I'd have to post on Facebook, and I didn't. I just had to scroll.
Right.
And everyone was talking amongst themselves. Um, at least back in what this is like 2018, I seem to be the only, if not one of the only clinicians in the group. And it was just boom, 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 constant, all the things that the cognitive impairments, the trauma, a lot of it, if not all of it, was related to these alternative experiences,
Right.
which
Right.
at the time I was still calling hallucinations, but I
Mhm.
really, after listening to you guys, I don't think that captures it, right?
Right.
These are real. And I was mortified
Yeah.
and kept thinking I would not have done this to people if I had known. There's no way. Like I had no intention of hurting people, traumatizing. Um, Also, I was kind of gaslit in my other ICUs when I would say, well, in my home ICU, we didn't sedate patients, we would just walk them. And
Right.
I did because I didn't know how to talk about it. I didn't know why we
Mhm.
did it. And everyone thought I was crazy. And they would say things like, well, your patients weren't sick. Your patients were more of like LTAC patients. You were rehabilitating them. And I'm like, no, but I
Yeah.
was only 2 years into my career when I started traveling. So I didn't have all these contrasting experiences. I didn't, in reality, that ICU was informally an ARDS unit.
Yeah.
We would get transfers from all over the region for ARDS because we had super high class pulmonologists.
Hmm.
That unit was renowned for their good outcomes with patients that were on ventilators for a long time. So um, we had a bone marrow transplant unit in the hospital, and those patients can develop ARDS so quickly. So we had a lot of really sick patients, difficult patients, but I didn't realize that until I came back and I was like, hold on, these are sicker patients than what I was treating as a travel nurse. And
Hmm.
yet they're up and they're awake and they're communicating their needs to me and telling me what they want and making decisions about their care and they're walking at the doors. Hold on. And so I just had never, again, connected the dots until the survivor told me about what was going on. I was like, oh my gosh. And I think I had treated so much delirium in the other ICUs. And yes, I would like, they call them CAM positive, right? I could identify the delirium, especially if they were agitated, but I didn't know
Right.
like what was going on inside the patient's mind.
Right.
I
Right.
wasn't concerned about it. I was like, well, they're confused. So is most of everyone here. This is just the ICU. But looking back, I'm like, yeah, we had some confused patients in my home ICU,
Hmm.
but they weren't like this out of control. It wasn't this common. It wasn't this bad.
Right.
I didn't go on for this long. I just didn't know that we were preventing that. I didn't know that we were treating that. Like I just didn't know
Yeah.
the big picture, but I didn't ask those questions or see in that light until I heard it from that survivor and then started to learn from more survivors. And I just kept thinking, my good colleagues don't, I mean, all these other people that I worked with in these 10 other ICUs, there's no way they know this. There's
Right.
no way. And why aren't we talking about this at the bedside? And I felt this weight of responsibility to
Right.
disseminate this. God would tell me, like, just whisper things to me, like, your calling is to disseminate this to the world.
Yeah.
And I'm like, yeah, not me. I tried having these conversations and no one believed me. I don't think anyone's going to listen to me, but that's cute, God. But yeah, we'll talk about that later.
Absolutely. So let's talk a little bit about that because a lot of people think when someone's heavily sedated, they're sleeping, they're having beautiful dreams. So sedation is not sleep, right? So, how do you explain those risks of deep sedation today to other clinicians that don't believe it? And also families, without scaring them, right? How do you explain this?
I go down to the basic physiology. So, explaining that sedation disrupts the brain activity and it makes REM cycle 3 and 4 impossible. So when you put all those EEG stickers on people's heads, right? If you're monitoring for seizures or whatever, you're watching the electrical activity in the brain, and there are certain patterns that you see for sleep. But when you have someone sedated and you're watching the same brain activity, it's all over the place. It does not follow the same sleep patterns. And so when you have victims of torture from sleep deprivation,
Hmm.
what happens to them? They develop hallucinations.
Right.
They develop severe PTSD, cognitive impairments, physical changes. They're at much higher risk of dying in the next year after that experience, even after they've, you know, gone back to normal sleep cycles, they've now are living a normal life. This is aside from critical illness. These are healthy people that just got put into a terrible situation
Right.
and they received less than 4 hours of sleep for 4 days.
Yeah.
And now, boom, their brain, their psychology, their bodies are different. Now you add on critical illness on top of that, and we're doing something similar with sedation. We're depriving their brains of sleep. So when I explain this to clinicians, especially nurses, we don't learn a lot about sleep. We know it's important,
Right.
but we also are taught to believe that this is sleep. So we're like, oh, sedation's good. Sedation sleep. Sedation means that they're not aware of what's going on. So let's turn it up at night to improve sleep.
Right.
And so it's all very backwards. So I always have to go back to the very foundation to say, here's what's actually going on. And we have to understand that sleep is so important to be able to cleanse the brain of the toxins, the inflammatory junk that's in there. I'm trying to keep it, language that's not super crazy, but there's a lot of buildup of damaging byproducts and things that are happening during critical illness, damaged tissue that we need to clean out, right? So I think of sleep like the garbage man.
Okay.
So I'll even explain to nurses and they just think I'm crazy. But at one point I had 3 kids with diapers.
Oh,
And so our garbage can would fill up so quickly.
right.
And when I knew it was garbage day, I was like paranoid about missing the garbage man, not have the garbage out at the side of the road, because I'm like, we're in a crisis here.
Right.
We have to have our garbage taken out. I think of critical illness as that kind of extreme, where we have so much garbage built up in our brains and we have to have the garbage taken out. We have to sleep to cleanse, to heal, to regenerate that damaged tissue that's happening just from the nature of critical illness. But then we deprive them of sleep,
Right.
and then they don't get that cleansing. So it causes neurodegeneration. It causes brain damage. It is a brain injury
Hmm.
that's happening. And so delirium is also called acute brain failure.
Okay.
And when I pose it that way to clinicians, you can just see the light bulbs go off. Because when we say acute renal failure, acute respiratory failure, we're identifying organs, vital organs for survival, that are failing, and now it's a medical emergency. Delirium to clinicians sounds like temporary confusion
Right.
that we can just sedate away and they'll get over it once they leave
Yeah.
the ICU, because it's ICU delirium. So when I say it's acute brain failure, they're like, oh my gosh, this is life-threatening organ failure. And it is. It doubles the risk of dying. So that's how I have to pose it, is go down to the very basics, build
Right.
it up, and then try to fit into the context to debunk what they've been bred to believe, right? These
Right.
are things that we've inherited from many generations before us. So before I even get to changing practices, we have to change how they perceive certain treatments that are so normal.
Right. Right. And as far as family goes, how do you explain that to a family? Because when you say they're going to be awake on a vent, possibly ECMO, they're worried that they're going to be in pain. So how do we explain that to the families?
Yeah, I think they also have to understand that during sedation with that brain disruption, the brain can't talk to the muscles. So they're laying motionless with their eyes closed because they are chemically restrained.
Right.
They are locked in, which I probably don't need to tell ARDS survivors that, right? But the families need to understand that just because they look comfortable doesn't mean that they are. It does not mean that they're not in pain.
Right.
So something that I have learned from survivors that has horrified me is the amount of pain that is felt, but then gets mixed in with these alternative realities.
Right.
So I am a huge advocate of pain management,
Hmm.
right? If people are in pain, that alone can cause delirium and trauma, increased mortality, things like that. But I want them to be able to tell me what they're experiencing. I want to know when I give them things for pain that it's adequate. I want to know if there's new pain. I've heard a story from a team that I trained. They had shortly after training, they had a patient that had a cardiac arrest. So she came in, and usually someone like that would have been sedated for a while. They had her awake right away, right after, as soon as she came up from the ER. They had
Okay.
her awake. She wrote on a clipboard and said, chest pain. She was having a heart attack.
Oh my gosh.
And she could have laid there, quote, sleeping
Yes.
for how long? And she would have had permanent heart damage because it wouldn't have been treated. But they got her to the cath lab. They treated it. They put in stents, right? They got blood flow back to her heart, and they saved her life because she was able to communicate her pain. So I think that's important for families to know that they can be assured that pain will be managed
Right.
because patients will be able to report their pain. And part of the family's really important role is to help their loved ones communicate.
Right. Right. Amazing. So let's talk a little bit about early mobility. So what does that look like in a patient on a ventilator or on ECMO? What does that look like?
You know, it really depends on where they're at, to be
Hmm.
honest.
Yeah.
So in many ICUs, early is subjective, mobility is subjective. So like how soon do we get them up? Depends on what the team is comfortable with. What kind of mobility, like are they sitting, standing, walking? Depends on obviously the patient's capacity. Could they walk before the ICU? Depends on the timing, depends on the unit. What is commonly done is we don't even take sedation off until we're trying to get them off the ventilator.
Okay.
And so by that time, especially with ARDS, it's been weeks.
Right.
So not only is sedation toxic to the brain, it's very toxic to the muscles.
Hmm.
It's a mitochondrial toxin. So you need your mitochondria to generate energy,
Right.
to respond to the impulses from the brain to the muscles. It also disrupts the sodium channels. So even when you have muscle mass and functional mitochondria, shortly after you've been sedated for a bit, you take a long time to respond to your brain because those muscles can't fire up
Hmm.
because the sedation's disrupted the sodium channels. So I don't know if that's too in the weeds, but basically you've got damage and dysfunction and atrophy or loss of muscle
Right.
very quickly. Now
Right.
that goes on for a long time. And now, as ARDS survivors have unfortunately probably experienced, your physical capacity is very limited.
Hmm.
I mean, you're kind of lucky if you can lift a finger off the bed.
Exactly. Yeah.
So now, what does mobility look like?
Yeah.
Now it's starting to rebuild that brain muscle connection, starting to
Right.
lift some things off of the bed. Now, in an awake and walking ICU, patients are not automatically sedated. So a lot of the ARDS patients I treated, even especially during COVID, were awake right after they had the procedure of placing the breathing tube, writing a clipboard. So they're using their fine motor skills and their muscles and their brain to write. They're using their cell phone. You know, they're holding their cell phone above their head. Like those are all muscles. That's all, some mobility. But then we're going to get them to the side of the bed and let them sit up. And a lot of times they can move themselves,
Right.
um, which makes it much safer and easier. I don't need to tell ARDS survivors how hard and taxing it is to start to do those things after that long.
Right.
But it's different when it's early on.
Hmm.
Yes, their lungs are sick. Yes, they're short of breath, but actually sitting up helps the lungs expand more. It helps them clear out secretions. It helps them not feel so panicked.
Right.
When you have really fibrotic lungs and you're almost laying down, sitting up fairly low level, that's not optimal breathing. That's a hard way to breathe. And now you've got a tube down your throat. So we use mobility to help people not feel so hungry for air, not feel so panicked, to breathe better. So I've had ARDS survivors or patients with a PEEP of 18 and oxygen at 100% be like, I don't want to go in the bed. Let me sit in the chair. Sometimes we try to prone them, but they do better walking than proned.
Right.
I mean, I don't think it's very backwards. So I have to explain that to ICU clinicians is being upright is so good for the lungs.
Hmm.
Now, sometimes now we have verticalization beds that can stand.
Yes.
And we know that standing has the same, if not more, benefits to lung function or VQ mismatch. I don't know how much you guys know, but as being proned. So I'm hoping that in the future, verticalization starts to replace some of our proning.
Yes, for sure.
And so again, mobility fluctuates by where you're at, the timing, the patient.
Yeah. Yeah, that's hard. And that's one of the biggest frustrations with survivors is having to rehab. Every single one says I can't even, push the call button when I need something because I'm just so far, you know, atrophied with my muscles. And that's the part that's frustrating, right? On top of having to deal with PICS and PTSD is the fact that so quickly their lives have changed and it could never get back to where it was, right? So if we can avoid that altogether, that would be amazing, right?
And that's something that I, as a clinician, didn't really understand. I
Right.
mean, it's crazy for me to think I worked in an ICU that did this certain care with patients, and then I was in a normal ICU, and I was like, well, they're weak, they're
Yeah.
sick. But the thing is, I didn't know them before the ICU.
Right.
So, and I wasn't taught to really value the muscles as a really important organ for survival or quality of life. I didn't know how long it was going to take for them to rehabilitate or what their lives were going to look like. So I wasn't panicked about it. So
Right.
even though, yes, I had prevented that kind of damage in another ICU, go into normal environment, and we're like, well, it's just the way it goes. So we don't see that as traumatizing. We see if they're awake and they have a tube down their throat as traumatizing. But from
Right.
survivors, I've learned, wow, that's real trauma not to be able to communicate, to
Yes.
be desperate to ask about your daughter or your dog and not be able to write on a clipboard and everyone else like, sorry, I don't know what you're saying. And then what? Turn sedation back on,
Right.
make everything go black again. Um, or just the panic and the frustration of not being able to hold a clipboard, use a call light, those basic things that are actually life-saving and essential, how much that impacts patients and survivors. So, as I talk about these things, I want you to understand how important that insight is and your perspective so that
Hmm.
you go back and you share it with your teams.
Yeah.
I know
Absolutely.
that survivors feel like they have to just be grateful that they survived, but survivors are what inspire us to change.
Right. Agreed.
We need your voices.
There's something in them that holds the key, right?
Yep.
Why did they survive and the other person didn't, right? There's something in that. I've said that forever,
Yep.
and one day we'll figure that out. But I
Yep.
feel like we're getting closer with things that you're doing and so forth. So let's talk about families a little bit.
Yeah.
What do you invite families to do in the room that measurably helps, especially when patients are delirious or scared?
Um, so ideally, like in an awake and walking ICU, and when I train teams, we actually work a lot on the family role. I think that was one of the biggest keys in an awake and walking ICU is we didn't have family visitation restrictions. So they can and would stay overnight, be there all the time, take rotations within their families, but they were part of the team.
Hmm.
And then working now with training other teams, I realized that that's not the standard. So we got to change that first of all.
For
But
sure.
then what do they do? What is the family job? And so uh, in the family education materials, I have a whole job description, a list of things that they are in charge of so that they understand how important they are. They know what to do. They can be helpful. Um, and early on, after someone's intubated, now that these teams will be waking them up, one team made this little handout so the families can take it into the waiting room and read it while they're waiting for intubation, or if they're coming up from another place like the ER, they can read it and think about it. But just giving them some heads up of, hey, they're going to have alarms going off. They're going to cough and they're going to gag initially. We know that. Don't panic. Your job is to be at the bedside, hold their hand, reiterate what's in their mouth, why they're there, and help them communicate.
Right.
That's their job.
Right.
And families can be so good at that. And I always tell clinicians, put the families on that because these people aren't going to trust you. They don't know you, but they know their loved ones. So
Hmm.
put them in charge of that. Things like giving them a mirror or putting their phone on backwards, like the camera on backwards, so that they can see the huge thing strapped to their face and the thing in their mouth.
Right.
And when I teach that to clinicians, we'll be just having a conversation. I tell someone, oh, hey, you've got something on their face, on your face. And they panic and they're like, oh, what is it? What is it? And they want to look at it. And I'm like, exactly. That's what we do to patients.
That's amazing.
So you've got this thing that's very uncomfortable, noxious, huge, and you don't look at it, don't touch it, just deal with it.
Yeah.
How are they supposed to handle that? So, I think there's a lot of empathy that needs to happen. So having families understand ahead of time,
Yeah.
yes, it's going to be uncomfortable, but we're going to get them through this um, with your help.
Yeah.
And we can treat their pain. We can treat their anxiety. We're going to do some things. It's not, so I always tell clinicians, it's not just about not giving sedation. It's what we do instead.
Right. Right.
But that's what clinicians are not taught. They don't know how to work them through these things. And
Right.
families don't know either, but we can give them clear instructions like holding their hand. Sometimes it's so simple, but in such a complex environment, we're afraid to bring in those simple things. But am convicted that those simple things actually bring huge results.
Absolutely. And as a previous family member of someone in the ICU, we just want to help. We
Yep.
just want to do something. We can't fix the ventilator. We can't give them pain meds. We need something to do so that we feel like we're helping, right? So that is so important to give them jobs so that they feel like they're helping because it's a very helpless feeling to just sit there and watch your loved ones suffer, right?
And they feel like they don't know anything. And sometimes the clinicians treat them like they don't know anything,
Right.
when in reality, they are the expert on that patient.
Hmm. Hmm.
So they know what kind of music they like. They
Right.
know what matters to them. They know how to help them preserve the will to live. They know
Right.
how to motivate them to mobilize. They know how to keep the calm. So you have an invaluable expertise as a family member
Hmm.
that can and should be utilized. Unfortunately, a lot of times in normal environments, it's seen as um, an accessory,
Right.
a back end thing, not as
Intrusion,
important.
an intrusion.
Yeah, and like if we're like, we're giving blood at high volumes or doing chest compressions, yeah, it's like not the time to hold their hand. But otherwise, those interventions are so important, and it's really key that families understand that they are wanted and needed.
Yeah. And that's what made, the whole COVID period so hard is no families, no families. So that brought on a whole nother set of problems for the patients, right? Not only were they sedated and delirium and PTSD, they didn't have their families. So such a hard time for sure.
It was insanity.
Yes. So where does respiratory therapist fit as a driver for liberation, not just ventilation?
Oh, I love that. Driver for liberation, not just ventilation. I may have to quote you on that. Um, yeah, we have to explain or remind respiratory therapists that we intubate to extubate.
Yeah.
And we need to be thinking about extubation right after intubation. Not that we're just going to be pulling that tube out right away, right?
Hmm.
But how are we going to prepare the patient to be off the ventilator as soon as possible? Because what happens with something like ARDS is the lungs are obviously sick. They need the extra pressure and support to get the oxygen the body needs, right? But while we're doing that with the ventilator, the diaphragm and the respiratory muscles are not doing the work of breathing. So they're quickly atrophying.
Yeah.
And then remember that how toxic sedation is to the muscles. So propofol, that white sedative, one of
Yeah.
our favorite drugs, is an independent risk factor for diaphragm dysfunction,
Hmm.
even without the ventilator doing the work of breathing. They took mice and they gave both two groups propofol. Only one group was on the ventilator. They both had the same level of diaphragm dysfunction. Wild, right?
Yes.
And then you're losing your like all, your chest muscles, your core muscles, all these muscles that are important for coughing, breathing, holding your head up, things like that. Um, and then you're causing delirium. So sometimes patients can't really wake up enough to cough and breathe, or they wake up and they're anxious and they get sedated again, and now they're on the ventilator longer. So there are all these things that we do as we're caring for patients with sick lungs that then create huge obstacles to patients being able to independently breathe after. So once the lungs are better, now we've got these other challenges that we have to now go back and treat.
Right.
So respiratory therapists have to understand that they're not just in charge of the alveoli and the trachea,
Hmm.
they're in charge of being part of navigating how do we preserve the muscle function and the brain, because that's part of breathing. And so that includes having patients be awake and changing the ventilator settings to be as comfortable as possible for the patient. There's actually a lot that they can do, but
Hmm.
they have to know how to do that, right?
Right.
So they need to be able to work with the patient to say, does that help? Okay, let's try this. How's that? They're just inspiratory, expiratory times that can make all the difference for patients. But when patients are just laying there and they're paralyzed and or sedated, they're not taking their own breaths, they don't necessarily have to do that.
Right.
So they need to figure out how to help patients be awake. There are things with the tube, like the tube position, letting the patients move it a little bit to the right or to the left, backward. Just a centimeter can get off the gag reflex and boom, makes all the difference. So again, it's like these like finesses that
Hmm.
can totally change what's going on in that moment and change the patient's experience and comfort. But when we do that, now we don't have to sedate them. Now they preserve their muscles and their brain, and now they get off the ventilator much sooner. So we intubate to extubate, and that requires the entire team to
Right.
be taking the entire patient into consideration.
Right. Agreed. So, what should post ICU follow up include to address things like post intensive care syndrome, PTSD, ICU delirium? What can we do for those that
Yeah.
were sedated and now we're dealing with this?
Yeah. And even if they, weren't sedated, delirium is and post-ICU
Yeah,
syndrome has the potential to impact anyone in the ICU.
absolutely.
But the risks are much higher if they've been sedated, especially for long periods of time, like ARDS survivors. They need cognitive, psychological, and physical rehabilitation.
Hmm.
And the physical rehabilitation gets the most attention because that's the most obvious, right? We can measure milestones like sitting, standing, walking.
Hmm.
Um, but especially psychological and cognitive, it gets swept under the rug. So there needs to be a safety net of you have these risk factors, you're at high risk of these long-term disabilities. We're
Hmm.
going to make sure you get follow-up care. So if someone has like an ARDS survivor, we know they're going to follow up with pulmonology.
Yeah,
We're going to
maybe.
be doing PFTs in X amount of time, right?
Maybe. Some are sent home with not knowing who to call next,
That's that
unfortunately.
no, that's just unfortunately so true, right? And they go to their primary care doctor, and it's like hopefully they get some kind of attention there.
Right.
So it's even less obvious with these cognitive and psychological
Right.
damages. And delirium is a brain injury.
Hmm.
So anyone of any age that's had delirium is at 120 times greater risk of having cognitive impairments at the same level of mild Alzheimer's or moderate traumatic brain injury. But the healthcare system doesn't see it as a brain injury.
Right.
And so you may be able to tell your physician or whoever is assessing you, I know what day it is, I know where I am, I know why I'm here, but then they're trying to articulate, but I seriously have a broken brain.
Right.
Something is not right. It's so different. So we need specialists like post ICU clinic that's ready to catch them on the back end and assist and that automatically sends them there.
Right. Right.
But we as clinicians, if we don't know what's to come, we don't know how to prepare them for it. So post ICU clinics are growing. There are more and more. We're working with telehealth to get more access to that. But there's such a huge need and demand. And so I know that survivors pass around some paperwork that says, hey, I think I have post ICU syndrome or I have post ICU syndrome, and that they can then educate their providers.
Yes. Yes.
But really they need speech therapy, occupational therapy, um, mental health therapists that are informed
Right.
about post ICU syndrome.
Right.
I see therapists doing the best that they can, trying to then go and understand what has happened and then guide their
Right.
patients through this. I think we need very specialized help on this, but survivors, I think, should be looking for at least trauma therapy.
Right. Right.
Now
Or
you've
support
got,
groups. At least support groups if you can't find that, right? Talk to other people that understand what you've been through. It's really helpful.
I do want to put a shout out for Dr. Brian Peach. He's at, I think,
Yes.
University of Florida. You probably talked with him. So
Yes.
those resources need to be shared more commonly throughout survivors, but survivors shouldn't have to be just like stumbling across a survivor that connects them to it.
Right.
So we need to make sure we're giving access to them. But again, survivors coming back and demanding these changes are what is going to get us a change.
Right. Agreed. So if you could rewrite one ICU policy tomorrow to better honor patient humanity, what would it be?
It would be to give every patient possible access to communication,
Yeah.
to see communication as a basic human right, to respect and preserve patient autonomy, the right to be informed, the right to make decisions, the
Right.
right to be seen as an individual with unique needs. We have worked on this sedation problem for so many years in ICU,
Right.
but the huge missing piece in perspective is communication. So we say lighten sedation, but if a patient is still lightly sedated and someone talks to them and they kind of open their eyes and like flutter their eyelids or whatever, they can't write on a clipboard and say, I have chest pain. Okay, here's another example. A podcast listener of mine said that he had a patient totally awake, hanging out, used the call light, had written on the clipboard before the nurse even came into the room, I have chest pain. They
Right.
did a chest x-ray and they found this huge pneumothorax.
Oh my gosh.
The patient had a respiratory arrest and they had to do CPR right then and there. And they knew exactly why it happened.
Right.
I'll tell you from the ICU side, a pneumothorax would not have been our first suspicion. It would have been like our seventh.
Yeah.
That could have cost him his life to take that long to figure out what had happened. But the ability to communicate, being fully awake and able to write on a clipboard, saved his life. So I am convinced that if we can get clinicians to focus on giving patients access to communication right away before they become too disabled, cognitively or physically too right, we're going to be able to actually keep patients awake and safe from delirium and actually able to mobilize them and prehabilitate them, protect them proactively from
Mhm.
delirium and ice-acquired weakness, rather than always face this challenge of rehabilitation on the back end. So if we can change that one thing, I'm convinced that the rest of it will come.
Yeah. Amazing. So let's talk about your podcast. If somebody is new to your podcast, is there one episode you think they should start with? Is it number one? Is it a different one? What should they start with?
I'd say episode number 1.
Yeah.
Yeah, it just starts with my journey. I mean, so this is 2020 that I started it. So, low tech. I was barricading my door for my toddler in my closet, but it's super honest. I didn't think anyone would listen to it. I was just doing what God told me to. And so I was like, hi, is anybody out there? Like, I think I've harmed patients on accident,
Yeah.
but I want you to know what we're doing in our ICU, right? Then the next episode is with Susan East,
Yeah.
which I think is so important because she knows both sides of it, being awake as well as being sedated.
Yes.
That episode changed everything for me.
Yeah.
I was definitely meant to meet her. And I think that's people talk all the time about how much that changed everything for them.
Yeah.
And so I think that's a good one for survivors to hear as well, that kind of sifts out what was just the environment, the equipment versus what was the delirium.
Mm-hmm.
I think survivors have every right to be very scared of the ICU.
Right.
But to hear Susan say, I'm not afraid of the ventilator or ARDS, which still blows my mind,
Right.
but I'm afraid of sedation. I would hope that would be very empowering
Mm-hmm.
for ICU survivors to be like, if I need care again, I'm prepared to advocate for myself. I feel confident it could be a different experience.
Right. Yeah.
And that can be life-saving.
Agreed. Susan's a wonderful person. She's actually co-founder of the ARDS Alliance. So yes, very important in the arts community for sure.
Yep.
So one last question for you. What one small daily habit keeps you grounded?
Prayer.
Prayer. That's a good
Yeah,
one
this
for
has
sure.
been a tremendous journey for me.
Mhm.
I started the podcast right as I was about to give birth to my third child. I now have 4, one
Um,
with special needs. We've been in and out of the hospital for her. And so just to say that it's been a very chaotic time, and yet knowing my why I'm doing it, why I'm here, and feeling guided helps keep me going and grounded. And I think that applies to anyone. Everyone has their own specific journey and mission. There's a reason that you're here. There's
Right.
a reason that you survived. And so reconnecting to your why, whatever that is for you, carries you through the rest of your day and helps you meet your challenges with a greater objective in mind.
Yeah, I love that for sure. Well, Kaylee, thank you so much for joining us today. And thank you for all your work, not only for ARDS patients, but for all patients in the ICU, right?
Well, I want to thank the survivors that are speaking out, reaching out, supporting each other. You are saving lives with your fellow survivors as well as current and future patients.
Right.
Every time I train teams, I do extensive webinars, didactic. We talk a lot about the research and numbers, and I think it's so impressive and compelling. I put a lot of time into those webinars, right?
Right.
Preparing them and giving them. When I go on site and I'm meeting with these clinicians about to train them, and I ask, what impressed you most about the webinars, or what do you remember? Because,
Right.
it's been a few weeks at least since the webinars, or months. 97% of people say the survivors.
Right. Right.
That's what finally opened their eyes It's really hard to consider that we've hurt people, that we've done things that were harmful that we didn't mean to, but it's the survivors that actually created that space and made that possible in their minds and made them willing to then change. And then that changes how they care for patients, and it changes an entire culture. It's changing the ICU community. And yes, I may have been a vehicle to having those voices be heard,
Yeah.
but it's the survivors being vulnerable and willing to talk about really hard things. They're grateful they survived for the most part. They're grateful to their clinicians, but that doesn't change. But talking about the reality of it and helping people understand the preventable harm that's happening is saving lives. So thank you to survivors for what you're doing, and I encourage you to keep doing it.
Thank you so much, Kaylee.